Hello friends, hi, I'm Dr. Shonali Chandra and I welcome you yet again to our YouTube channel Medicine Decoded. We're dealing with bleeding in early pregnancy, and in the light of those videos, I have come up with another case scenario, which is that of molar pregnancy. Now we've answered those questions already, that what exactly is a molar pregnancy. Now we're going to talk about the clinical case presentation and management of an hydatidiform mole. So my discussion today is going to focus mainly on a complete molar pregnancy. However, I'll also highlight the important differences with a partial molar pregnancy as well. So let's get started and let's have a look at this clinical case scenario. So there's a 20-year-old primigravida who's come to the casualty with 3 months of amenorrhea. Now her complaint is that of excessive nausea and vomiting and some irregular vaginal bleeding for the last 1 week. Her home-based urine pregnancy test is positive. Now there is your first clue. I mean that there is obviously first trimester bleeding in pregnancy. That's definitely there. But other than that, the excessive nausea and vomiting, I mean, there could be other causes of excessive nausea and vomiting. I mean, there could be a multiple pregnancy with excessive nausea and vomiting. It could be a coincidental gastritis or some GI problem with excessive nausea and vomiting. But yes, it does, click here something that could be a molar pregnancy. Now we move ahead. We check her vitals. Should come with bleeding. Her vitals are stable. Basic examination, we followed that. Cardiorespiratory examination is normal. You establish that the bleeding is mild. There's some off and on lower abdominal pain. On per abdomen examination, you realize that she's saying that she is 3 months pregnant, but her uterus is enlarged to 16 weeks in size, right? So it is enlarged beyond doubt. And what is the differential diagnosis now? A woman who's come with bleeding, excessive nausea, vomiting, uterus enlarged more than the period of gestation. So your differential diagnosis is definitely molar pregnancy, comes top of the list. Other than that, it could simply be an abortion with coincidental excessive nausea, vomiting, with abortion with wrong dates. It could be that. So it's very important to ascertain that yes, indeed, she is 3 months pregnant. Other than that, multiple pregnancy, right? Other than that, polyhydramnios. I mean, it could be a multiple pregnancy and polyhydramnios that is leading to a 16-week size uterus, or it could be a fibroid uterus with incidental with a pregnancy. So this is the long list of differential diagnosis which could be there. Now just let us add to our clinical examination a bit and figure out and see if we can eliminate these differential diagnoses thereof. So what we see here, I'll just use a pen. What we see here, that the uterus is enlarged to 16 weeks size. The fetal parts are not palpable. I mean, yes, I mean, palpation of fetal parts become much easier beyond 20 to 22 weeks, but nonetheless, fetal parts are not palpable. The important clue here is you've tried maybe by a handheld Doppler, and your fetal heart sounds are not audible. So you cannot auscultate the fetal heart sounds. On PV examination, you confirm that yes, the uterus is enlarged to 16 weeks size. The fornices are non-tender. There is no tenderness through the fornices. But what you can see here is that there are bilateral adnexal masses about 5 centimeter which are felt through the fornices, right? So an enlarged uterus, fetal heart sound not heard, and some adnexal masses. I mean, these adnexal masses could be coincidental adnexal masses, but if it has to be coincidental, bilateral coincidental adnexal masses, I would probably think in terms of maybe a molar pregnancy with theca lutein cyst, isn't it? Maybe a molar pregnancy with theca lutein cysts. I mean, it could be an abortion with wrong dates. I agree there. But then for that, I'll have to confirm whether she is indeed 3 months or 12 weeks. So I would ask her for her LMP. I would see I would check the reliability of the dates. I would see if there's an early scan or whatever. And yes, by some means or the other, I would confirm that she is indeed 12 weeks. So that would give me a clue here. Multiple pregnancy. or even a polyhydramnios, you should be able to auscultate the fetal heart rate at 16 weeks by a handheld Doppler, even in these scenarios. And multiple pregnancy will also have excessive nausea and vomiting, that's also there. But based on this current entire clinical profile, the points which are going in favor of a molar pregnancy are bleeding as the most common clinical presentation, right? So bleeding. Other than that, there is also a uterus that is enlarged more than the period of gestation. The fact that fetal heart rates are not palpable, fetal heart sound is not heard. The fact that there are bilateral adnexal masses which could be theca luteins, all these factors are going in favor of molar pregnancy there. So all of these are differential diagnosis. One way to confirm, a very simple way to confirm, do an ultrasound. You do an ultrasound of the pelvis and you find out if it's a molar pregnancy, if there is an intrauterine pregnancy with an absent cardiac activity, if it's an abortion with wrong dates, you find if there are 2 fetuses, you find if there's 1 fetus with excessive liquor, maybe sometimes with polyhydramnios also it becomes difficult to auscultate the fetal heart rate because of excessive distension of the uterine cavity. But nonetheless, ultrasound will definitely be required to confirm your diagnosis at this point. Even at this point, if they had asked me what is the most likely of these 5 scenarios, I would have said molar pregnancy tops the list, right? Now, moving on further, whenever I'm suspecting molar pregnancy, you see, always be mindful of the fact that complete molar pregnancy is more often encountered in clinical situations. Be mindful of the fact that if you're suspecting molar pregnancy, you can ask for additional clinical features, right? Like you could ask for the history of tremors, right? I mean, this excessive nausea and vomiting is happening because of excessive beta HCG. The same excessive beta HCG could lead to excessive stimulation of the maternal thyroid gland and could lead to a hyperthyroid-like state, and that could lead to tremors. A history of breathlessness. You see these cystic elements of these cystically distended chorionic villi which are present in a molar pregnancy, they could sometimes, can metastasize by the venous circulation to the lungs. I mean, they could lead to pulmonary emboli and then can lead to the complaint of breathlessness as well. So when you're suspecting molar pregnancy, be mindful of this and ask about these symptoms as well. Now, let us have a look at the ultrasound findings. So we suspected molar pregnancy, we went ahead and did the ultrasound, and this is what I found. Let us just have a look at the management first. So while we are managing, we have to confirm the diagnosis, right? So we have to confirm the diagnosis by doing an ultrasound. That will help us rule out all the differential diagnosis. Secondly, once we do come to the diagnosis of a molar pregnancy, we have to set in a pre-treatment evaluation in place. And finally, we have to plan a definitive treatment. And we also have to plan for a post-treatment follow-up. So let us just talk about these 4 separate points independently. So I'll talk about confirmation of the diagnosis here. So on this figure on the left, this is an ultrasound image. You can see that the uterine cavity, this is showing you the uterine cavity, and this white arrow is showing you the contents of the uterine cavity. And they are cystically dilated chorionic villi, and there is no fetus inside. There is no fetus inside. There is just cystically dilated chorionic villi, and this is what you call as the classic snowstorm appearance on ultrasound. And this is characteristic of a complete mole, right? On the other hand, on the figure on the right, this is to help you differentiate that there is a possibility that there could be a fetus inside which is dead, okay? And there could be here, this area here, there could be a cystic placenta. Now, if this is the report, if this is the ultrasound report, this will often be labeled as missed abortion. At the end of the ultrasound, this will often be mislabeled or misdiagnosed as a missed abortion. What is this? This is probably a case of partial mole. So if there is a patient who's come with excessive nausea and vomiting, a clinical profile fitting into the description of a partial mole, right? Ultrasound probably misdiagnosing it as a missed abortion. It is not the sonologist's fault, but it is most of the times misdiagnosis, missed abortion. We can assess by checking for beta HCG. You see, the beta HCG is going to be excessively increased in both molar pregnancies, be it partial mole or be it complete mole. Right? Now, in a case of complete mole, the beta HCG is usually more than 10 to the power 5 international units per liter. And in partial mole, beta HCG is usually less than 10 to the power 5 international units per liter. I am saying usually, not always. So, beta HCG could give us a clue. So, a clinical profile fitting into the description of a molar pregnancy, an ultrasound probably misdiagnosing as missed abortion with an excessively raised beta HCG as compared to a normal intrauterine pregnancy could raise a suspicion of a partial mole. However, partial mole is rare in comparison to a complete molar pregnancy, but nonetheless, your ultimate diagnosis or 100% confirmation of a molar pregnancy would be by a histopath. Right? So, we will need to evacuate these contents, be it a snowstorm appearance, right? We need to evacuate the uterus of these contents. We need to evacuate the uterus of these contents and subject them to a histopathological evaluation, and that will give you confirmation whether it is a partial mole or not. And that is why in routine clinical practice as well, whenever we are evacuating missed abortions, you see, whenever we are going for evacuation of missed abortion cases, one should always subject them for histopathological evaluation, always. Okay. Now, having said that and confirmed our diagnosis, at the end of this slide, you might be pretty aware now that the management is fairly simple. I mean, these are chromosomally abnormal fertilizations. You see, there is no future. So, you need to empty the uterus of these contents. So, evacuation has to be done. But what you also need to understand here is that you need to go for a pre-treatment evaluation. So, what is that going to be? And let us just read out the report that we found in our particular case. We were doing our case scenario. Now, we'll read the report that our patient showed, okay? So, our patient showed this. Ultrasound showed a heterogeneous mass inside the uterine cavity with cystic spaces. No fetal parts were there. The endomyometrial junction is well preserved. That's an important point that the sonologist has given to me in the report, that the endomyometrial junction is well preserved. That means that this molar tissue is probably most likely not invading the myometrium. So this molar tissue is most likely probably not an invasive mole, but only a complete mole. So that is what I am getting by this ultrasound report. Now both ovaries are enlarged and cystic, measuring about 4 centimeter. And look what the sonologist has also given me information that the liver, the spleen, the bilateral kidneys, everything else looks fine. There is no free fluid in the peritoneal cavity. So this is the entire report, which is suggesting that it is indeed a case of a complete mole, not an invasive mole, or not most likely not a case of a gestational trophoblastic neoplasia. Now moving on further, let's talk about the pre-treatment evaluation. So what do we have to evaluate for? Again, whenever you have to subject a person to a surgical intervention, you need to have blood group and RH typing report there with you, a complete blood count, a baseline liver function test and a kidney function test, a baseline HCG levels, baseline chest x-ray, and screening for hyperthyroidism. This is the pre-treatment evaluation in the case of a molar pregnancy. Now you would ask me, why is a baseline LFT and KFT needed if the woman is not in shock? Well, the reason for this liver function test and kidney function test evaluation is that at a later point in time, women with molar pregnancies during follow-up, or maybe when the bleeding is persistent and not improving, may need methotrexate therapy. For that reason, it is always important when you are taking the blood sampling to take a baseline LFT and KFT levels as well. Second reason why baseline is needed is that with such an enlarged uterus, with molar pregnancy, while you are surgically evacuating the uterus, there is always a possibility of excessive bleeding on table or post procedure. Right? So you need a baseline evaluation for LFT and kidney function tests as well, liver function test and kidney function test as well, because they might progress or they might worsen after. Right? Baseline beta HCG levels are also needed. Why? Because again, follow-up of molar pregnancies has to be done with beta HCG. Right? A long duration follow-up is needed. Now for that, if you want to compare whether the beta HCG is dropping down or is it rising or is it plateauing, you need to have a baseline value to compare it with. So you need to have it here, right? And a baseline chest x-ray, because you see those small cystically dilated glands, which I told, cystically dilated chorionic villi, which I told you could go into the lungs. Even small bits, micrometastasis could be in the lungs. With pulmonary emboli features, she might not be breathless visibly, but she could show some evidence of those deposits in the lungs. So baseline chest x-ray to begin with is required, right? And screening for hyperthyroidism as well. And one can skip this, but if the woman is having features like tachycardia, which is out of proportion to her bleeding, okay, tachycardia which is out of proportion to her bleeding, making you think maybe it's because of hyperthyroid status, or she's having evidence of tremors, then you would definitely not like to skip this screening for hyperthyroidism as well. Now let's see what our patient showed. Our patient showed that she's A positive, her hemoglobin is 8, TLC is fine, platelet is fine, liver function test, kidney function tests are normal, chest x-ray is normal, and serum beta HCG is 1 lakh international units per liter. So I had an ultrasound diagnosis of a complete molar pregnancy. Now I have a pre-treatment evaluation whereby her baseline status looks fine, except for the fact that she's definitely anemic and her serum beta HCG is quite raised. Now with this information in mind, I will plan the treatment. Now the treatment of choice is suction and evacuation, right? Keeping in mind that her HP was 8, I would definitely like to keep blood in hand ready if required, because again I'm expecting that possibly during the process of expulsion she could bleed a lot, and then I would have to depend on blood transfusion because she's already 8 grams per deciliter, mind you that. So the treatment of choice is suction and evacuation. And mind you, it's not dilatation and curettage. I mean, curettage you can do at the end of the procedure of suction and evacuation. Look at this here. So you have a uterus here which is filled with cystically dilated chorionic villi, and you want to give her curettage, right? So if you want to do her curettage with such an enlarged uterus, how long will you keep curating? Till the uterus is empty of its contents. So the fastest, surest way, best way is to do a suction and evacuation, right? So we put in a suction cannula and we suck out the contents, right? Now you would ask me, why not a medical evacuation? Why not give her drugs to contract the uterus and just do medical evacuation? Why not that? Because when you're going to make this uterus contract forcefully, like probably using misoprostol in first trimester, so if you're going to do that, you see there is a possibility that these small chorionic villi, those dilated chorionic villi, can seep into the maternal circulation, right? Venous circulation. So from the branches of the uterine veins to the iliac veins, and then to the inferior vena cava, and then to the lungs. And there is a slight theoretical risk, at least, of causing a pulmonary embolism. So that's why the best possible scenario or the best possible treatment of choice is a plain and simple suction and evacuation here. All right. Now, next question is, our patient also had bilateral theca lutein cysts. So, do we need to do any additional treatment for those cystically enlarged ovaries? I mean, our patient also had, this is the ovaries, both side theca lutein cysts. Do we need to do anything for this? No, we don't need to, because once the source of beta HCG is coming from these chorionic villi. Once we have done suction evacuation, the source of that excessive beta HCG is out. These theca lutein cysts are going to regress on their own. They will regress in the next 2 to 4 months post evacuation. Right? I mean, it is beta HCG itself which is causing the excessive stimulation of the theca cells of the ovaries, leading to theca lutein cysts. So once you've done the suction evacuation, about 2 to 3 months post evacuation, as the beta HCG levels drop down from the bloodstream, the theca lutein cysts are going to spontaneously regress on their own. So they don't need any additional treatment unless, of course, there is an ovarian torsion associated with it. Otherwise, usually no separate treatment for theca lutein cyst is required unless there is ovarian torsion along with it. Now, some of you might argue that, and it has often been argued, that what if it's a woman who is completed her family, she is more than 40 years of age, and she does not need any more children. In that circumstance, can we do a hysterectomy straight away? Why not? Let's just get rid of her uterus. I mean, does that make sense to you? Does that make sense to you? That just because a woman has completed a family, does not wish to procreate any further, she's had a molar pregnancy, a complete molar pregnancy, or a partial molar pregnancy, which is by itself benign, should we counsel for hysterectomy straight away? I don't think so. Hysterectomy is a major surgical procedure with its inherent set of intraoperative complications, right? So we don't need to do an unnecessary surgical procedure unnecessarily, right? An invasive surgical procedure unnecessarily need not be done. Moreover, after doing hysterectomy, you see, why even do a hysterectomy? Because you see, what people argue is that doing a hysterectomy would completely eliminate the possibility of having a pulmonary embolism at all, because you've just completely removed the uterus. That is one theory that they give, those who want to advocate for a hysterectomy. But I would say that the chances of pulmonary embolism are in itself very, very rare. Secondly, why I want to argue against a hysterectomy is because of the repercussions that will happen because of hysterectomy per se. Intraoperative complications, yes, and of course it has been seen that after 3 to 4 years of a hysterectomy, or maybe 5 years down the line, the ovarian functions also start to wane off. Now, I don't want a woman to end up in a premature menopause for something that I have done iatrogenically and for something which is a benign indication per se. Moreover, you see, does hysterectomy, the question is, does hysterectomy completely eliminate the possibility of a molar pregnancy progressing to gestational trophoblastic neoplasia in the future? I mean, if that would have been the case, hysterectomy could have been justified, but that's not the case. That's not the case. Even if you remove the uterus, there are still possibility that micrometastasis from these chorionic villi might have already seeped into the abdominal organs or seeped into the lungs. So you don't know for sure whether by doing a hysterectomy, you will absolutely make the possibility of gestational trophoblastic neoplasia or progression to gestational trophoblastic neoplasia from molar pregnancy a complete zero. You can't assure that. So I would argue against a hysterectomy routinely in cases of a molar pregnancy which is by itself benign. So you see here what the reference has been taken from the textbook, which is Novak's, Berex and Novak's from Gynecology, and this is what they write, that if the patient desires surgical sterilization, a hysterectomy may be performed, and even then the ovaries may be preserved at the time of surgery. Hysterectomy does not prevent metastasis. Patients still require follow-up with assessment of HCG levels. So if you ask me, I would probably be saying, okay, hysterectomy is possible when it is a woman who's completed her family, wants a surgical sterilization, is aware of the inherent risks of hysterectomy, also agrees to that procedure, and also is prone to lost for follow-up, because the follow-up of beta HCG follow-up after molar pregnancy evacuation is very, very long. So only in case when a woman is prone to being lost for follow-up would I consider that, but it is not routinely justified at all in cases of a benign molar pregnancy. Hysterectomy is not justified routinely at all. So may be performed, maybe, okay, that too not in all cases where women want sterilization, mind you. Now, moving on further, let's have a look at what happened to our woman once we did the suction and evacuation. Let's see. That 20-year-old primee with a complete molar pregnancy in bilateral theca lutein cysts with anemia, that was a diagnosis, right? Remember, her HP was 8, a baseline HCG level of 1 lakh, underwent suction and evacuation, received 2 units of blood transfusion along with it, and repeat HCG after 48 hours was 50,000 international units per liter. And immediately after her evacuation, what we realized that the bleeding has stopped during the observation of those 48 hours. I'm happy. At the end of this, I'm happy. I do not want to give her anything else. I do not want to give her methotrexate. I do not want to give her prophylactic chemotherapy, as we call it. So now let us talk about what are the indications, what are the situations where you would want to go for a prophylactic chemotherapy. In my patient, she's 20-year-old primee and her beta HCG is falling down, her bleeding has stopped, I have taken care of her anemia, I've given her 2 units of blood transfusion, I'm observing her. I don't want to give, you see, a prophylactic chemotherapy. Chemotherapy by itself has side effects, you see. All therapeutic agents, and the one that we use for gestational trophoblastic neoplasia is methotrexate. So we don't want to give it unnecessarily unless it is indicated. So there is no routine prophylactic chemotherapy. Okay, even in high risk molar cases, there's something called as high risk molar pregnancies. These are molar pregnancies who have high risk of progression to GTN. High risk of progression to gestational trophoblastic neoplasia. What are those? Those high-risk molar pregnancies are if the age of the woman is more than 40 years, if it's a complete mole rather than a partial mole, okay, complete mole rather than a partial mole, if it is if the uterus size is more than 16 weeks, right, if the bilateral theca lutein cysts are more than 6 centimeters, and also if the HCG levels are more than 10 to the power 5 international units per liter. This is a system of finding out what are the high risk molar pregnancy, that they have a likelihood, more risk of progressing to GTN, gestational trophoblastic neoplasia, but not always. And a combination of factors would give more risk as compared to isolated factors in place. My patient has no such factors in place, or no such combination of factors in place. Even if there is a high risk molar pregnancy, even if all of these factors are present, even then the latest recommendation is that one should refrain from rampantly using prophylactic chemotherapy. Okay, so what is the current recommendation? Current recommendation is against rampant prophylactic chemotherapy, because once you keep giving chemotherapy to each and every case without any indication, it breeds drug resistance. So if at all that woman later on develops GTN, the same chemotherapeutic agents might not work. So what are the indications of giving chemotherapy after molar pregnancy evacuation? Justified reasons. Bleeding is persistent. We've done the evacuation and the bleeding doesn't stop. Now, persistent bleeding after evacuation raises the possibility of invasive mole. Raises the possibility of invasive mole. If there's an intraperitoneal bleeding, an invasive mole, yes, an invasive mole, you've done the evacuation, okay, nothing is inside the uterus, you've done that. Maybe it's an invasive mole. Maybe it's an invasive mole that is eating into the myometrium. Maybe that eating is so extensive that it has perforated the uterus and now leading to intraperitoneal bleeding. So if there is persistent bleeding, intraperitoneal bleeding, then that raises the possibility of invasive mole. Raises the possibility of invasive mole. I mean, then it is justified to give a post-evacuation chemotherapy. If there are rising or plateauing beta HCG values during follow-up, or even after 4 weeks of evacuation, the beta HCG still continues to be more than 20,000 international units per liter. I mean, that would be a justified indication of giving a post-evacuation chemotherapy. And prophylaxis may be useful in the management of high-risk complete molar pregnancy, and that too not in all cases, especially when the HCG assessment for follow-up are unavailable or are unreliable. Right? So what is the general consensus? The general consensus is now the standard of care is that after molar pregnancy evacuation, one should refrain from rampantly using prophylactic chemo. There is no prophylactic. Get rid of that term prophylactic chemotherapy. There is indicated post-evacuation chemotherapy. One indication, persistent bleeding. That is giving you the suspicion of invasive mole. One indication, intraperitoneal bleeding, which is raising the possibility of invasive mole. A rising or plateauing serum beta HCG on follow-up, again raising the possibility of Gestational trophoblastic neoplasia. Another indication, high risk complete mole, especially when the HCG assessment for follow-up are unreliable or unavailable. Then it is justified. So remember, post-evacuation, indicated chemotherapy is what is recommended now. And to finish off the topic for today, this clinical case scenario of molar pregnancy, let us just talk about the follow-up. Okay, so follow-up after evacuation. Now the question is, why is this follow-up needed? Why are we following up? We are following up with beta HCG, weekly beta HCG, but why? Because it is during this follow-up that we might pick up GTN. GTN, gestational trophoblastic neoplasia, can arise after any pregnancy event, but most commonly arises after a molar pregnancy event. It is absolutely unrealistic to follow each and every pregnancy, be it abortion, ectopic, or a full-term pregnancy. It is absolutely unrealistic to follow every pregnancy with a beta HCG, isn't it? There's so many pregnant women, so many events that happen in pregnancy. I mean, it is absolutely unrealistic. But with molar pregnancy, after molar pregnancy evacuation, we need to follow, because most of the cases of GTN are seen after a molar pregnancy event. However, GTN can arise after any pregnancy event. So what is the risk of this subsequent GTN with a complete mole or a partial mole? Well, the risk of subsequent GTN with a complete mole is about 15 to 20%. And that for partial mole is about 4% here. Okay. And when you say GTN, GTN involves invasive mole, choriocarcinoma, placental site trophoblastic tumor, endothelial trophoblastic tumor, all of those things are included in GTN. So overall risk of GTN is 15 to 20%. But the risk of subsequent choriocarcinoma, particularly with a complete mole, is about 4%. And with partial mole is less than 1%. So look at it here. For most of the complete moles, you see here the risk of subsequent GTN is about 15 to 20%. And that's a significant enough risk to justify a follow-up, right? So how long is follow-up done? Well, follow-up is done with weekly beta HCG levels, serum beta HCG levels. And that has to be done till 3 back-to-back consecutive normal values. And after that, monthly for 6 months. So that's a long follow-up. Now the next question that arises is that how long does it take on an average for beta HCG to become normal? Okay, it's a long follow-up, but what are you expecting? What is the average time taken for beta HCG to normalize? So, well, with complete mole, you see, understand, very simple. Higher the beta HCG level to begin with, the longer it will take to normalize. So if you consider normal pregnancy, full-term normal pregnancy, vaginal delivery, beta HCG normalizes in about 2 weeks after delivery. With a complete mole, beta HCG is right there, off the roof. So it takes longer. It takes about 9 weeks on an average for the beta HCG to normalize. And in a case of partial mole, it takes on an average around 7 weeks for the beta HCG to normalize. I mean, it could be lesser than this, it could be more than this, but we're talking about the average time taken for the normalization. Now, next question that arises is that should the woman become pregnant during follow-up? Should she become pregnant? What is the problem? What is the problem? right? Why is contraception required during follow-up? That's the question. It's not like that she can't become pregnant during follow-up. It's not like that. But what will happen if she becomes pregnant during this long period of follow-up is a fresh pregnancy will give rise to fresh secretion of beta-HCG. Now, if that happens, my follow-up is ruined, because in my follow-up, I was following it up with serum beta-HCG. That was what I was tracking. So fresh HCG from a fresh intrauterine pregnancy is going to interfere with the follow-up. Therefore, contraception during follow-up is a must. And combined oral contraceptive pills, progesterone only pills, injectable progesterone, barrier methods, all are fine. The drug of choice, though, is oral contraceptive pills, combined ones. But please, your progesterone only contraceptives, be it pills or injectables, your implants, progesterone implants, be it your barrier method, they're all fine. They're all safe. They're all fine. What should not be used? Not used at all, contraindicated, is Copper-T. Any intrauterine device, be it Copper-T, be it Mirena, is contraindicated. You see, if you have a uterus like this here, there is a possibility, there is a foci of invasive mole here, and you put an instrumental device here, you put a Copper-T or you put a Mirena here, and you have an invasive mole here, the chances of this device perforating increases. So therefore, during follow-up, any intrauterine device should not be used. So this is about the case scenario of a molar pregnancy. You start with a clinical presentation, then you start with the differential diagnosis. You should know what the differential diagnosis are. You should then know how to come to your diagnosis. You should be wary of missed abortions, because sometimes your partial moles, in fact most of the time, your partial moles are misdiagnosed as missed abortion. So be wary of that. If ever you are evacuating missed abortions, subject them to histopathological evaluation post evacuations. And do not forget beta-HCG baseline. It happens that in the rush of things we just forget to send the beta-HCG sample. That should not happen. It will give you a clue to your diagnosis as well, because it's going to be unnaturally high as compared to a normal intrauterine pregnancy. And secondly, you need to have a baseline value in place for follow-up, right? So once you have made the diagnosis and confirmed it, you have to have a pre-treatment plan on the evacuation, right? Refrain from unindicated, unjustified hysterectomies. Refrain from routine prophylactic chemotherapies. No, that should not be done. It should be indicated. And insist on, educate the patient about the need and necessity of this longish follow-up, and ensure that during the time of follow-up she is on some or the other contraception, right? So you need to put this entire system of management for a molar pregnancy in place, because with molar pregnancy comes two things. One thing is to deal with that pregnancy at that time, that is the evacuation part. The second thing that comes with molar pregnancy is the progression, risk of progression to gestational trophoblastic neoplasia. That also has to be taken into account. And what gestational trophoblastic neoplasia is, what are the various clinical presentations, how are we going to diagnose, how one treats, is a topic of another discussion altogether. But I hope that you found this lecture useful, and I will see you soon with more and more such clinical case scenario based videos. Thank you so much, guys. Thank you for listening. Bye-bye.